Another concern that has been raised is US government funding and what is the ministry doing about that. As we know, the global fight against HIV, TB, malaria is mainly supported by PEPFAR, PMI, Global Fund, and UNAIDS, and all deriving quite an amount from USG. Kenya has been overly dependent on the donor-driven vertical health programs, and yet there was a stop work order which has disrupted USG funding worth 30.9 billion. HPT being 24.9, HRH 5.8, HMIS and health system strengthening also being affected. Additional multilateral funding for vaccines, nutrition, family planning of about 17.2 billion are also at risk. And then the public health security may result to service disruption because of lack of commodity security, HRH, and data systems being affected. So what is the status? Currently, we have 1.4 Kenyans living with HIV on ART, and we are at risk of having 58,495 new infections by 2030 if donor funding is reduced. For TB, we are likely to have 23,500 TB annual mortalities, among them being 20,000 people living with HIV. And for malaria, we're likely to have 12,000 deaths per year, with projected increase because of climate change. And for family planning, 6.2 million who rely on family planning annually are likely to be affected, and yet the gap of 40% has not been reached. Regarding vaccine, coverage currently is at 77%, and the program currently under transition from donor to government funding. So that coverage of 77% is likely to be hampered. So as we said, for commodities, 24.9 is by US government, 79.8 to Kenya, and 79.8 health commodity need. That is 24.9 out of the 79.8 commodity need. And we are engaging diplomatic interventions. On Wednesday, we'll be meeting the US acting ambassador, and we are also developing an impact assessment of which we will be sharing with the various development matters and diplomatic for interventions. We also need to allocate 24.9 billion for commodities previously funded by USG, and disburse 2 billion allocated, and allocate additional 2.5 for vaccines to avert funding freeze by Gavi. For HRH, we have 41,547 PEPFAR-funded staff affected. And after reviewing, the technical team reviewing this, we saw that 11,559 frontline health workers would be core in terms of transition and implementation, and their cost is 5.84 billion. And there's need for us to approve comprehensive HRH restructuring and highlighting with public health systems. So 41,000, but 11,000 core, 41,000 having been able to support us in implementing the 98, 98, 94 targets. And again, we look to capacitate the team that will continue with the interventions. For data, USAID funds 139 million for critical health-based databases, including Kenya EMR, among others. And we are happy that we have a digital platform, so really it's on time, and we are really ensuring that we are transitioning to the digital and integrating those critical data so that we don't lose important patient data through the cracks. Other critical programs are the blood transfusion program, where 2.8 billion World Bank support is ending in March 2025, and we are securing other funding. This is because one of the high causes of maternal mortality is hemorrhage, postpartum hemorrhage, and so we need to address blood transfusion concerns. Immunization and vaccines, 11.6 billion is required. Gavi and USG support, again, is at risk, and the recommendation will need disbursement of 2 billion immediately and allocate 2.5 billion for Gavi compliance. Family planning require 2.7 B. USG was 598, GOK 508 with the 1.7 form funding gap. And the recommendation is to allocate 598 for continuity and consider 1.74B in 2025-2026. Equally for nutrition, 4.96 billion required, 2.88 from USG is at risk, and will replace USG funding with domestic allocation. So in summary, you can see from the various pillars or departments, the total is actually coming to 30.922 billion that we require for seamless transition